Now we will move on to the next topic, that is the sphincter is relaxed too much. Till now it is not relaxing, it is eclasia. Body is hypermotility, it is DES or nutcracker. Now the problem is the sphincter is relaxed too much. So what are the causes? Tea, coffee, alcohol, smoking, pregnancy, obesity, high fat diet, drugs like anticholinergics, barbiturates, calcium channel blockers, diazepam, prostaglandins. These are all the causes. Okay. So can anybody tell me why pregnancy?
Because of the fetus, the baby.
Because of the
baby.
fundus, when it expands, it pressurizes on the.
Okay.
Intra-abdominal pressure increases.
Intra-abdominal pressure increases. That is one reason. But another important reason is there. That is due to progesterone. Pregnancy, there will be hyperprogesteremia. Though this progesterone has a relaxing effect on all the sphincters. Okay, on some sphincters, not all the sphincters, and some sphincters. So esophageal sphincter will be relaxed. So they will have reflux of contents. So because of progesterone in pregnancy, and tea, coffee, alcohol, obesity, fatty diet, everything, almost everything is the same. So the most common symptom, the patient will have heartburn. They will tell it as heartburn. Okay, and most common complication is reflux esophagitis. Same like in eclasia, it is the same. Most common commonly reflux esophagitis. So what is the investigation of choice here? Here is reflexing. Sphincter is relaxed. So the reflex here, that is 24 hours ambulatory pH monitoring. So what they'll do is they'll just put a small probe inside. Okay, they'll put a small probe inside and in the esophagus. Suppose this is the esophagus. They will put a small probe within the esophagus. So whenever the acid is refluxing, this probe will note it. Because acid reflux will happen, it will not happen continuously, it will happen intermittently. Whenever there is acid refluxing, the monitor will be measuring this and they will give a score finally. That score is known as Demister score. Okay, it is the next level. No need to remember this, but just for come Demister score. With the help of this Demister score, we will tell whether there is reflux GERD or not. Okay, so what is the investigation of choice for eclasia?
High resolution manometry.
What is the investigation of choice for GERD?
24 hours ambulatory pH monitoring.
24 hours ambulatory pH monitoring. Ambulatory, the patient should move. He will not be bedridden or he will not be in the hospital. Okay, the patient will be moving. Then only we can find when the acid is refluxing. Okay. Yes.
So
No.
can you please show the slide before investigation? Yeah, the one before this. So the one before this, sir.
Sorry.
The one before this, a slide before investigations. Okay, sir. Thank you.
So then the complications, most of the time it is reflux esophagitis. Okay, no need to think much. Is it obvious, right? There is esophagus is there, it is regarding reflux, so it is reflux esophagitis. Sorry. And there will be nocturnal asthma. Why nocturnal asthma? Because reflex, this is what is LPR. Anybody LPR in our medicine classes are over?
Not yet, sir.
Okay. So LPR is laryngopharyngeal reflex. Laryngopharyngeal reflex. So because of this reflex, there will be nocturnal asthma. When the patient is lying down in the night, he will have asthma. So once you in medicine, when a patient comes with asthma, we have to give some routine medications for asthma, and we have to see if still it is not controlling. Then we will think of some GERD may cause asthma only in this nocturnal asthma cases. Okay. So other complications are because of this there will be stricture formation. Because of reflex, there will be stricture formation. The stricture is most commonly seen in the lower end of the esophagus. the lower end of the esophagus, there will be stricture formation. And this is known as a Jackie's ring. A Jackie's ring. It is also most common in the squamocolumnar junction. They are nothing but they are, because of this reflex, they are small submucosal constrictions. Okay. There will be narrowings. The normal esophagus, suppose this is the normal esophagus, the esophagus will be reduced in size because of peptic stricture or Jackie's ring. And then Barrett's esophagus. This is little important. What is the epithelium? What is the normal epithelium of esophagus?
Squamous epithelium?
Non-keratinized squamous.
Yeah, it is non-keratinized, it is squamous epithelium. So this epithelium, because of the gastric reflex continuously, our body has to modify it. Squamous epithelium cannot tolerate acid. So it changes into columnar epithelium.
Columnar epithelium.
Okay, the lower part, this is the esophagus. The acid is getting reflexed into the lower part of the esophagus. So what happens is this picture, this epithelium, this is normally squamous, will turn to columnar epithelium. Okay, if it turns to columnar, what is our problem? It is okay, right? If body has accustomed, what is our problem? Why we are worried about it?
Cancer.
Intestinal metaplasia.
Sorry?
Intestinal metaplasia.
Yeah,
cause
this
cancer,
is intestinal metaplasia. So why are we worried about it? It's nice, right?
Progresses to malignancy.
Very good. So this change will not stop at that point. Okay, it changed from squamous to columnar. If it stops at that point, it's okay.
It's a pre-malignant
But
condition.
yeah, it will turn into malignancy. Okay, and there will be presence of goblet cells. This is also important. There will be presence of goblet cells. Okay, in the columnar epithelium. So we have to take. We cannot leave that patient. Once if the patient will have a esophagus, will have this columnar metaplasia. How to identify this columnar metaplasia? By doing endoscopy. If there is a salmon pink appearance, remember this word, salmon pink appearance. Salmon pink appearance, salmon pink patch, we call it as. If this is there, then it is an indicator that the esophageal lining has changed from squamous to columnar. So we have to take a biopsy. That biopsy is we take with the help of this Seattle biopsy protocol. But just remember, we have to take biopsy. In biopsy, if there is no dysplasia, repeat the endoscopy at 3 years. If there is low-grade dysplasia, repeat the biopsy at 1 year. If there is high-grade dysplasia, remove the esophagus completely. Do surgery because it is almost malignant. Okay, and the risk is 40 times higher risk for malignancy. And which malignancy? Adenocarcinoma is more prone to happen. Adenocarcinoma, not squamous cell carcinoma. Okay, is this clear? Barrett's. Again, I am repeating. Barrett's esophagus. It's a complication of GERD. Number 1. Number 2, the squamous epithelium will turn into columnar epithelium with goblet cells. Number 2, it appears as salmon pink appearance on an endoscopy. If there is salmon pink appearance, we have to take a biopsy. Fetal biopsy protocol. We will take a biopsy. And what does this protocol show? If there is no dysplasia. What is dysplasia? What is dysplasia? Come on. It is a precursor to malignancy. Yes.
Conversion of one cell type to another.
It's an abnormal change in the.
Yeah, it is not a normal change, it's an abnormal change. Okay. So if there is no dysplasia, okay, you can repeat the biopsy after 3 years. If there is dysplasia, low grade or high grade. If low grade, repeat the biopsy of 1 year. If there is high grade, treat it as
Surgery. We have to do surgery.
yeah, treat it. No. If it is high grade, what will you treat it as? You will treat it like
Adenocarcinoma.
yeah, adenocarcinoma. Very good. Okay. So treatment, what can you give? For this one I am telling. For GERD, what is the treatment?
PPI.
Excellent. So the only thing which is available is PPIs, proton pump inhibitors, omeprazole, desmoprozole, pantoprazole. Okay, this is the only treatment available for proton pump inhibitor. Surgery very rare. Nowadays we are not doing because of this excellent proton pump inhibitors. For proton pump non-responders, there are people who will not respond with proton pump non-responders. So for them, you have to evaluate completely for motility disorders. There is any motility disorder or there is any sphincter abnormality, you have to see. Okay. And impedance manometry is a type to know the type of reflex. This is not necessary, but just impedance manometry is a variety of manometry to know the type of reflex, whether only the gastric contents are reflexed, whether food is being reflexed. So to know the type, we need to do an impedance manometry. So indications for surgery, only few people we need to do a surgery. Before we go into indications, what surgery we'll do?
We'll do a fundoplication to tighten the.
Yeah, very good. So the indication is we need to do a fundoplication. We need to do a fundoplication. Fundoplication. So what are the indications? High volume reflex of acid, stress, poor compliance with drugs. If some people proton pump inhibitor will cause gynecomastia and also we can't give to them. Complications of GERD like Barrett's esophagus or patients with LPR. What is this LPR?
Laryngo
Laryngeal reflex. In these cases, we have to go for a fundoplication. Okay, fundoplication is nothing but this is the esophagus, this is the stomach. So we'll just wrap the stomach fundus around like this. We'll wrap it like this. Okay. So fundoplication is nothing but it is wrapping the fundus of the stomach around the esophagus to prevent reflux. So there's some named surgeries like Nissan's fundoplication, Taupet fundoplication, Door fundoplication, and Mark fundoplication. Okay, Nissan, Taupet, Door, and Mark. Just names. Okay. And the complication of fundoplication is the patient will have ileus. What is ileus? Anybody? What is this ileus?
The lack of bowel sounds.
Lack of bowel movement. Peristalsis, lack of bowel peristalsis. That is the most common side effect of fundoplication. And this is a recent advance. This procedure. So they might ask you radiofrequency ablation. Using high energy radiofrequency waves, we can ablate the abnormal mucosa. Suppose this is the mucosa which is abnormal. We can put a radiofrequency machine inside it and we can ablate it. The procedure is known as Stretta procedure. Okay. Yes.
Where is it used?
For GERD only.
Okay.
GERD in abnormal cells, abnormal mucosa is there. Just you put the high frequency probe and you activate it, so that the mucosa will get charred off and it will become normal again. Once the healing, after healing, it will become normal again. So this procedure is known as Stretta procedure. Then we'll move on to the next topic, hiatal hernia.
So can you just show that slide again?
Yeah.
That image. Strata, and then after that, sir?
Procedure, Strata procedure.
Okay, so that's what you've written. Strata and then procedure.
Strata procedure.
Okay.
Yeah. It is nothing but it is a radiofrequency ablation procedure. That's all.
Okay, sir.
Okay.